We will now be seeing some case-based scenarios that we commonly see in neonatology. Case 1. A 3.8 kg baby born at term, emergency LSCS in view of fetal bradycardia. Baby was born limp and did not cry after birth, had ABG scores of 1, 3, 3 at 1, 5 and 10 minutes respectively. If we look at the ABG analysis of this baby, we can see that the baby has high anion gap metabolic acidosis, and in the clinical scenario, this baby most likely suffered from prolonged severe birth asphyxia. Case 2. This was a baby born at 40 weeks period of gestation with 3 kgs weight, born again by emergency LSCS in view of abruptio placentae. Baby was born limp and did not cry after birth with ABG scores of 3, 3 and 7 at 1, 5 and 10 minutes respectively. Looking at the ABG of the baby, we see that the baby has respiratory acidosis, and this could be a severe birth asphyxia case due to an acute event, unlike the previous case. Another cord ABG which shows severe acidosis, but in this case it is both respiratory and metabolic. So a severe birth asphyxia with severe mixed acidosis. Case 3. This was a baby born at 24 weeks 3 days period of gestation with birth weight of 590 grams by preterm vaginal delivery. At 30 hours of life, baby was found to have increased ventilatory requirement in the form of increased FiO2 and pressure requirement. The baby also had thick purulent secretions from ET tube while suctioning. At 48 hours of life, the baby was found to have poor perfusion, feeble pulses, hypotension and scleroderma. The ventilatory settings of the baby have been shown as above. If we look at the ABG of the baby, we see that the baby is having mixed acidosis with raised lactate levels and high anion gap. In the clinical scenario and the ABG which we have got, the possibilities that would be kept in this baby would be early onset neonatal sepsis resulting in septic shock, and also a differential of hemodynamically significant PDA needs to be kept in this case. Our next case is a baby born at 26 weeks period of gestation with birth weight of 1080 grams. At day 3, baby had multiple episodes of apnea requiring bag and mask ventilation followed by intubation. The vitals of the baby were stable. The baby was on minimal ventilatory settings. Looking at the ABG of the baby, we find that the baby is having acidosis, which is predominantly respiratory. In the clinical scenario and seeing the ABG of the baby, the differential we would like to keep in this baby is partial tube lock, hemodynamically significant PDA, pulmonary interstitial emphysema, or a collapse of the lung. Baby born at 26 weeks 3 days period of gestation with birth weight of 665 grams, initially managed with ACV mode of ventilation. On day 5 of life, baby developed features of pulmonary hemorrhage and shock. In view of the clinical condition, the baby was started on HFO mode of ventilation in view of persistent hypoxemia. Looking at the vitals of the baby, we see that the baby is having tachycardia and SpO2 of 90%. The ventilatory settings on the HFO mode of ventilation have been depicted in the slide. Looking at the ABG, we see that the baby is having metabolic acidosis and hypoxia. The hypercarbia in this case is iatrogenic, which is a common phenomena that occurs when the babies are put on high frequency ventilation with high amplitude. Hence, in this case, we need to titrate the amplitude based on the CO2 levels that we get in the ABG report. Next case is a 28-weeker born with birth weight of 1020 grams. On day 4 of life, the baby had progressive increase in FiO2 requirement and respiratory distress, following which the baby got intubated. The ABG of the baby showed mixed acidosis, both respiratory and metabolic, And differentials in this case would be a hemodynamically significant PDA, early onset neonatal sepsis, PIE, that is pulmonary interstitial emphysema. The next case is a baby born at 39 weeks period of gestation with birth weight of 3200 grams. Baby was born by normal vaginal delivery with antenatally detected large VSD and ASD. Baby developed features of CCF on day 10 of life. Was started on decongestive measures. The ABG in this case showed metabolic alkalosis with respiratory compensation. The cause in this case would be prolonged use of furosemide. In our next case, baby born at 39 weeks 4 days period of gestation with birth weight of 2568 grams. On day 3, baby was found to be lethargic, having persistent vomiting and reduced urine output. However, the vitals were stable with peripheral pulses being well palpable. The baby had reduced tone with poor sucking efforts. The random blood sugar done at that point of time was found to be 68 mg per deciliter. If we look at the ABG of the baby, we see that the baby is having metabolic acidosis with high anion gap and respiratory compensations. In the clinical scenario, we need to suspect inborn errors of metabolism. However, septic shock also needs to be considered as a close differential. If in the similar baby we have a ABG which shows respiratory alkalosis instead of metabolic acidosis, a clinical suspicion of inborn errors of metabolism, predominantly urea cycle defects, needs to be kept. Baby born at 27 weeks period of gestation with birth weight of 720 grams, on ventilatory support since birth, on day 4 of life, found to have urine output of more than 6 ml per kg per hour. The ABG done on this baby shows metabolic acidosis with normal anion gap, a common scenario that we usually see in extreme preterm neonates. The differentials in this case would be renal immaturity, and a close differential of sepsis always needs to be kept as a close differential. Coming on to the take-home message from all the above cases that we have discussed. ABG needs to be interpreted in conjugation with complete clinical status. Trends of ABG are more important than a single report. Pre-analytical errors needs to be ruled out in case we find values which are not matching with the clinical status. All the basic steps of ABG analysis should be followed before drawing the conclusion.